Welcome everyone to today's webinar, This Routine Screening Saves Lives, but Many Americans Go Without. Geisinger is trying to change that. Sponsored by Exact Sciences. I'm Gabrielle Mason from Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. It's now my pleasure to introduce today's presenter, Nicole Trieste. She is the Director of Ambulatory Care Gaps and Best Practice for Geisinger Health System based out of Danville, Pennsylvania. She has been with Geisinger almost 11 years, the last 7 of which have been working with primary care and various members of the care team to improve workflows, efficiency, and the overall clinical quality provided to patients. Previously, Nicole obtained her Bachelor of Science and Master's of Business Administration degrees from the University of Rochester in Rochester, New York. She also worked as a registered nurse in critical care at the University of Rochester Medical Center for 4 years. Nicole is passionate about ensuring patients receiving the best possible care at each and every access point. At this time, I'm pleased to turn the floor over to Nicole to begin the presentation.
Thanks, Gabby. I'm extremely honored and humbled to have been asked to present on the work that Geisinger has done around colorectal cancer screening over the last few years and for the time that I've been involved. We've really seen some nice improvement in our screening rates. We've implemented many proactive initiatives, which I'm going to review some of them with you today. But we still have some work to do to get to 80%. So thank you for joining today, and I'm going to go ahead and get started. So during the webinar, as you are all aware, this is around colorectal cancer screening. I'm going to give an overview on our efforts to improve our rates. By the end of this webinar, my hope is that you're able to understand the possible barriers, or at least the ones that we've experienced, to implementing a successful CRC screening program. I'm going to focus on a lot of the technology and leveraging that technology that we've implemented to optimize our CRC screening process. Hopefully you'll understand how shared decision-making impacts CRC screening rates and has become a big part of our offering of it. And also, I hope that you're able to learn how we've leveraged our analytics to establish our benchmarks and goals for CRC screening rates and really promoting accountability to achieve our desired outcomes. This has been a key driver for us. Folks truly needed to understand where we were at with compliance at both an individual provider and at a system level, as well as understanding what our goal is and where we want to get to. So I have a pretty little map of our service area in the state of Pennsylvania. We have approximately 55 FAM-Prac or internal medicine practices across our service area. We have over 300 providers. We have actually, it's closer to 350,000 attributed patients to our primary care sites at this point. And we divide our regions into 4 hubs. So we have the Northeastern hub, which comprises Scranton and Wilkes-Barre, as well as the surrounding areas. Our Central hub is where our main campus is in Danville, Pennsylvania. The Western hub is our State College area, or Penn State campus area, and its surrounding areas. And then our South Central hub, which is Harrisburg and our Holy Spirit service area. Very diverse regions and populations. So in the Northeast, we have Scranton, Wilkes-Barre, very populated cities. We move into the West or the Central region. We have a very large Amish population, so we have hitching posts at some of our sites for the horse and buggies. And then you go out to the West, very educated, affluent community in the Penn State area. So we serve a wide variety of patients and communities. So most of you are familiar with this already, but I'd just like to start off with some very high-level facts about colorectal cancer screening. I think it really sets the stage about what we're going to talk about today and the relevance and importance of it. So, we know nationally, excluding our skin cancers, CRC is the third most common cancer diagnosed in both men and women across the United States. It's treatable in 90% of the people when it's caught in the early stages based on a 5-year survival. Myself and our Chief Quality Officer at Geisinger, we often say no one should ever die of colorectal cancer because if you screen early enough, 9 times out of 10, it can be treated successfully. And then certainly, we all know ensuring timely screening and rescreening can impact outcomes, the detection, the survival, and the cost of treating colorectal cancer. So this is just some information about our state of Pennsylvania when it comes to colorectal cancer incidence and mortality. So the national average and this is based on 2016 data, our national average at that time was 38.7 per 100,000 people. Pennsylvania is at 41.9, so we are above the national average in the incidence of colorectal cancer. The national average for mortality was 14.2 per 100,000. And again, sadly, Pennsylvania is at 15.3. So in both of those areas, incidence and mortality, we are higher than the national average. So certainly not just Geisinger, but Pennsylvania as a whole has some work to do around improving our screening rates. We at Geisinger have really focused heavily on value-based care. So, a number of years ago, we've seen that shift coming from a fee-for-service model to a value-based care model. Prevention is key at being successful in that value-based model. Over the years, we've seen life expectancy has decreased, while on the flip side of that, health spending has increased. Patients of all income levels, it really doesn't matter, are facing the financial burdens of those healthcare expenses. And so just a little data for those of you that appreciate it like I do. This is based from 2017. Our healthcare spending per person in the United States was a little over $10,000. The next lowest per capita spender was Switzerland at a little over $8,000. That's almost 22% lower, so really significant. And then when it comes to the health of our population, we've really seen an increase in folks with chronic conditions, and more than one of them. So CMS has predicted, and this number is just mind-blowing to me, that 117 million people have one or more chronic diseases. 1 in 4 people have 2 or more chronic health conditions, which again is why it's so critical that we focus on prevention. And then certainly we have a large volume of the aging and retiring baby boomers. So how does Geisinger identify those patients that should be screened for colorectal cancer screening, or screened for colorectal cancer, and then subsequently rescreened? We're going to touch on a number of analytics in a little bit, but our basic criteria comes from the US PSTF recommendations to identify those who are eligible. So we identify our population, whether it be external outreach or within our electronic health record, as those patients who have a Geisinger primary care provider and those patients who are 50 to 75. They have not had a completed colonoscopy in the last 10 years. They have not had a completed FlexFig in the last 5. They have not completed Cologuard in the last 3. Or they have not had an FOBT or FIT completed in the last year. Or the last one is within our EHR, a provider has the ability to permanently discontinue colorectal cancer screening if clinically appropriate. So again, they have not had that implemented in the EHR as well. So those are the folks that we identify as being eligible and needing colorectal cancer screening and or the subsequent rescreening. So at Geisinger, we've identified a number of barriers that, we think have driven patients at times away from colorectal cancer screening. For you today, I've grouped them into two buckets. Those that we think are patient-driven and really require more education for the patient, or those that are system-driven, so things that are internal to us that we need to work and improve upon. And I think a lot of these are going to be familiar to most of you. But certainly, there's still misconceptions around the colon prep and how much time it takes to complete the prep and actually have a colonoscopy itself. And so we know today those prep times and the procedure times, they're much shorter and easier than it used to be. But again, patients don't know this. The fear of an invasive procedure itself, awareness of the screening options. So we know there are many options out there, and they're not all invasive, and certainly not invasive if it's clinically appropriate. And then the cost. It's not always, quote unquote, free. And we experience that within Geisinger, anesthesia costs, hospital costs, et cetera. So it's not always free to the patient. Patients also feel that if they don't have any symptoms, there's not a family history of it, they don't know anybody that has it, that they don't need to be screened. We all know that is not the case. So really education around the importance of screening regardless. And then the frequency. So it's not just something that's one and done. Certainly if a patient has a colonoscopy and it's normal, they can go 10 years, but certainly some of our other options, they have to be done on a routine basis. May vary, but every 1, 3, or 5 years. In terms of our internal Geisinger, what I would call, again, system-driven barriers, one of our barriers over the years has actually been GI access for colonoscopies. We have one particular area that we've struggled with recruiting and access. And there is a couple month wait time for screening colonoscopies. That is something that we've actively been working on improving. Provider and staff education. So making sure our providers and our nursing staff, folks understand what the screening options are, what are the pros and cons of both, what is most appropriate for the patient, and that they're able to have those meaningful and engaging conversations with the patient. Technology. So I'm a data geek, so I love talking about the technology and the reporting we have at Geisinger. And I think this is an area where Geisinger has truly excelled at, not just in CRC screening, but a lot of the other areas. We have a very robust technology foundation and reporting resources. And I do believe that this has been crucial in our success and in our success at improving. What I'm showing here is one of our reports we developed, I started rolling out in 2012. It's amazing that it's been that long, but it's what we call the AMP report, and it stands for Anticipatory Management Program. This is something that I call one-stop shopping for our patients and for our site. So, we get data from multiple places. We have best practice alerts. So we utilize the EHR Epic. So within Epic, we have best practice alerts. We have health maintenance. We have other gaps in care that aren't in the EHR. And so there's lots of places and resources that folks were needing to go to see what gaps in care the patient had. So this is what I would call a very patient-centric report that can be used at point of care or pre-visit planning that shows all of the open gaps, it pulls in all of the gaps from those various sources into one report. It's updated daily. Our hope was that it would help to increase our productivity of our staff, takes re-engineers work away from our providers and staff. So again, if folks can be successful at implementing this pre-visit, they can look at the report for Bonnie Smith and 2 weeks before her appointment and see that Bonnie is overdue for X, Y, and Z. Reach out to Bonnie. Let's see if we can get it ordered, scheduled, and completed prior to her appointment. When that can happen and Bonnie comes in and her results can be reviewed, it's the most effective and efficient use of truly everybody's time. You know, if you're not able to use it for pre-visit, certainly at point of care, it's a comprehensive list of everything that Bonnie would be due for. The other thing that it helps with is, and we've done, is built-in automated workflows to help with care gap closure of those metrics that are identified. So I will show you our best practice alert for colorectal cancer screening. But building in, you know, again, optimizing our technology and building in those automated tools to help our providers be more efficient within the visit itself. And then certainly all these tools help our providers and staff engage our patients in the shared decision-making process. Here's just an example of what our AMP report looks like. So at the very top of the report, you'll see number of open gaps. We put our risk admission and ED score at the top so we can identify those that are at higher risk and make sure they have the appropriate resources that they need. You'll see some basic patient demographic information followed by some basic appointment information, so date, time, who are they seeing, when was the last time they were seeing, what are they being seen for. And then you'll see the open gap section. So I found one where it identified colorectal cancer screening. So with this one, there was no order for anything in the last year. So the patient did not have an order for colonoscopy, did not have an order for Cologuard or an FOBT or FIT. They were overdue for colorectal cancer screening. And then you'll see on the left side of the open gaps, there's the asterisk. And what that indicates is, and there's like a little key a little bit further down, but those open gaps with asterisks are what we consider nurse responsibility. So those are things that the nurses can address in advance of the provider seeing the patient. So like while they're rooming the patient, we have nursing protocols built where nurses can place the order, sign it, based on evidence-based practice. And then you'll see the next section is previous diagnoses. So this is for our HCC coding and capture, identifying things that have codes that in diagnoses that have been identified and utilized in the past and still have the opportunity to be captured in this calendar year. And then below is information on future and previous appointments. So this we had added to really help eliminate any unnecessary appointments and to help with schedule smoothing. So, you know, we know patients that have tons of appointments and sometimes they're close in together and don't need to be and they don't get canceled maybe when they should. And so this is just a really nice quick snapshot to be able to identify those opportunities and make sure patients' appointments are appropriate. And then certainly making sure they have the appropriate follow-up. So for example, maybe I have a very brittle diabetic that should be seeing endocrinology. I look on here, have they seen endocrinology in the last 6 months, or do they have an upcoming appointment with them in the next 6 months? If not, then that's something I can encourage that they schedule at checkout. So I talked a little bit about our best practice alerts. So these are those automated workflows that we've built into our EHR to try to help our nurses and providers be more efficient. It's real-time alerting within the EHR when our patients come in for their office visit. with the best practice alert is an associated smart set with the appropriate documentation tools and order sets for that open gap. In this case, it's colorectal cancer screening. It alerts, or what we would say fires, for the nurse while rooming the patient. If the nurse ignores or declines it, again, because this is one that we've designated a nursing responsibility and have a nursing protocol around, but in the event the nurse ignores it or declines it, this alert will then fire for the provider during the provider visit with the patient. So you'll see as well, for CRC screening, we, Geisinger, consider the colonoscopy our first option, or our reference standard for colorectal cancer screening, followed by Cologuard, and then followed by FOBT or FIT testing. Now, certainly, not every patient is clinically appropriate for Cologuard or FOBT, but we start with the colonoscopy and then we go from there. And again, this is really where shared decision-making comes in, because a patient may not be agreeable to a colonoscopy, which is fine. We talk about all the options, and then it's talking to them about what's clinically most appropriate for them, and then hopefully making a good educated decision and getting them in for whatever test they decide and that's most appropriate. We also have, these are pretty neat. So again, probably about around the same time frame, 7-8 years ago, we developed what we call our Happy Birthday and Chronic Disease letters. So these are obviously not at point of care. These go out, this is external outreach to the patient. But our Happy Birthday letters are sent, and I have an example in the next slide, but they're really, our Happy Birthday and Chronic Disease letters are really used to help address these gaps in care, outside of the office visit. If our patients are active on our health portal, they will receive these letters electronically through the health portal. If it goes unread after 7 days, a snail mail letter will drop to the patient. If the patient is not active in our health portal, patients will receive the letter via snail mail. And so our Happy Birthday specs, our Happy Birthday letters are sent to patients the month of their birthday if they are active within our primary care, so they've been seen within the last 2 years. They are alive, and I always have to say that, because that's important to make sure that you are only contacting patients that are alive and not deceased. They have one of our Geisinger primary care providers as their PCP. Our adult letters are for those 19 and older. They do not have a temporary or confidential address. They are a resident of Pennsylvania. We do have some folks that in other areas that are out of state. They are not currently in palliative care. They have not been dismissed from a particular practice. And then it doesn't go to everybody, but it's really focusing on those patients who have not been seen by their provider within the last 90 days and don't have a scheduled appointment with their provider in the upcoming 90 days. Our chronic disease specs, very, very similar to Happy Birthday, but they are sent 6 months post the patient's birthday. And these letters are targeting those patients that have one or more qualifying chronic diseases. So, CAD, diabetes, COPD, a number of our chronic diseases. We have 2 types of chronic disease letters that go out. So it's those patients that do not have a scheduled appointment with their provider. And then the second version are those that have a scheduled appointment. Certainly those that don't have an appointment, we want to get them in for that. Those that do have a scheduled appointment, there's a little bit more emphasis on their open gaps in care. And then with the Happy Birthday letter, and I will show you an example right now. On the left-hand side is the Happy Birthday. On the right-hand side is the chronic disease. So, our Happy Birthday is happy birthday. It's a great present to yourself is getting a clean bill of health. We want you to get scheduled and get seen by our providers. And then below that is the patient's health calendar. So We have gaps in care that are due right now or overdue within the last 3 months. Those gaps in care that are overdue from 3 to 6 months, and then gaps that are due in 6 months or more. And hopefully this helps the patient plan for the care they need based on what gaps they have and when they're due. And then on the right-hand side is our letter for chronic disease. And so I know that these slides will be available to folks after the presentation and the event. It might be hard for you to read, but really happy to share these. We've had really nice success with folks receiving these in the mail. They're like, oh, I haven't been seen in a while. I have a bunch of things that I need to have done. And then certainly they call our scheduling number and they get scheduled for an appointment. The first part of this is, certainly we can identify those patients that are overdue for colorectal cancer screening. We can offer it. They could say yes. But we know that we oftentimes have patients that will say, yes, we place the order, but then they don't do it. And then what? And so these are what we refer to as our close the loop initiatives. We've implemented multiple ones related to colorectal cancer screening to ensure the completion of that screening and or completion of the diagnostic testing if that initial screening was positive. So we are very fortunate to have what we call Care Gaps Health Coordinators in primary care. They are assigned anywhere from 4 to 6 sites, primary care sites, and it's based on volume and attribution. So we try to spread the sites out evenly. But they are responsible for the patient panels at those sites and helping to close gaps. We start with the patients that have the greatest number of gaps and work our way down. And we consider them they are a part of the care team, and they have a shared responsibility with the operations and the leadership at those sites for improving, our quality metrics, and in this case specific to colorectal cancer screening. So a couple of the close the loop initiatives that this group works on is one is for Cologuard and one is for FOBT or FIT follow-up. So when it comes to Cologuard, these folks will outreach to patients that have had Cologuard ordered anywhere from 60 to 90 days ago, and they've not returned their kit. So they reach out to the patient, they ask if they have any questions, any concerns, do they still have the kit, and really encourage the return of that kit. This group also will outreach to those patients that have had either a positive Cologuard or a positive FOBT or FIT who have not had a follow-up colonoscopy to get them scheduled so the patient could get that completed. When it comes to colonoscopies themselves, our GI and scheduling team will outreach to those patients who have canceled or no-showed their colonoscopy appointment to reschedule and, again, answer any concerns or questions that the patient may have. So, for us, just as important as ordering the CRC screening it's just as important to make sure the patient actually has it completed and, again, quote-unquote, closing the loop on that. So you'll see I'm going to show some dashboards and some reports. We love them at Geisinger, and they've truly, we don't build a report or build a dashboard unless it truly has meaning and really serves an important purpose. And what I'm going to show you today are tools that we've built over the last few years that I think do just that. So on the screen now is what we call our CRC Screening Dashboard. It's internally developed at Geisinger, but it gives a view of what our compliance is for each of the various screening methods, as well as it gives us the ability to drill down to patients and to a provider level if you wanted to, within each of those screening methods to aid in our Close the Loop initiative. So our Care Gap staff utilize this dashboard to identify their patients at their assigned sites that they need to reach out to quote-unquote close the loop on. GI and scheduling also utilizes this for those patients that have canceled or no-showed their colonoscopy. Mentioned in the beginning the importance of shared decision making, and this, in general, shared decision making is a key component when it comes to patient-centered healthcare. It's truly our providers, our nurses, working with the patient, working together, partnering with the patient to help them make the best decisions, select tests, treatments, and care plans that are most appropriate for them. Again, balancing the risks, the outcomes, and the patient preferences, as well as keeping in mind evidence-based practice. But this doesn't come naturally to everybody. I think, this is a relatively newer concept over the last few years, shared decision making, and really having meaningful, engaging conversations with patients, especially those that aren't as activated or engaged in their care, and trying to have them be agreeable to the care that we feel is best for them. And so, a lot of this comes down to leadership and site education. So ensuring that our leadership understands the importance of this, and then it flows downhill. It gets to our frontline staff. Frontline staff have to be able to, number one, they have to know the importance of preventative screening. But they also have to have the ability to convey that to patients in a productive and engaging way. Being able to address any of the obstacles or barriers that I alluded to earlier. They need to understand where we're at, why it's important, why are we doing it, where do we need to get to. We partnered, and this really helped, I think, in our journey around our education efforts for shared decision making. We had folks from Exact Science come to all of our primary care sites, provide education to our providers and staff, not just about Cologuard, but colorectal cancer screening in general. But then certainly, being a resource for providers and staff to be able to ask specific questions around Cologuard. Exact Science was kind enough. We have a demo Cologuard kit in every one of our primary care offices to be able to show the patient, this is the box that comes in, this is how to open it, this is what it looks like, this is what you need to do, this is how you put the solution in once you've given your sample, this is how you package it back up. I think which has been really, really instrumental, again, in improving our rates, because patients are able to see it, we explain it to them, so it's not foreign to them when they receive it in the mail. And then I've already really alluded to this, but when I talk about the engaging conversations to have with patients, it's motivational interviewing. And we had some of our education staff go out to our sites and really meet with providers and nursing staff to help them improve upon having a more engaging conversation with patients when addressing those preventative care measures. And again, like I said earlier, especially those patients that are much more difficult to engage. And here's a copy of our shared decision-making tool that we co-branded with Exact Science. So just some really high-level fast facts about what colorectal cancer is and screening. And so, looking at those numbers, they're scary to people. Not that we want people to be scared, but we want them to recognize the importance of having screening, to not become a statistic. And then certainly we talk about the easy screening options that there are. And so it's colorful, there's graphics, it's the size of a regular piece of paper that our providers can review with the patient and the patient can take home with them. So, we have patients that, and I'm sure a lot of you know this, that see patients. You may have a conversation with them and they leave, and they may not, it was very overwhelming for them. They're non-clinical. A lot of information was given. Sometimes they forget it. This is a really nice hands-on tool that they can take home with them and have as, a reference or education material about the importance of colorectal cancer screening. The other thing we've done, and this has been more recent, I would say in the last 2 to 3 years, we've really amped up our marketing efforts around colorectal cancer screening. I would say we target and do the most marketing in March during Colorectal Cancer Screening Awareness Month. But we do a number of things. So you'll see a picture there. It's this is called the colossal colon. It is an inflatable colon that we display for one day at all of our hospital campuses in the month of March. And folks, it's such a discussion piece. Folks come, we have some props, they can take their picture in it. And for this year, it was pre-COVID, thank goodness. But folks can have their picture taken. We have the local news station come. We have a GI surgeon and provider on site to answer questions around colorectal cancer screening. We had reps from Exact Science. We had somebody there that could schedule colonoscopies. If it was one of our patients and they were overdue, we could get it scheduled, or we could order Cologuard or an FOBT or a FIT. So it's really, I mean, this has been, folks have just really enjoyed this every year. To get more of our staff engaged throughout our healthcare system, we offered this year was actually the first time we did it, a CRC bulletin board contest for both our inpatient and outpatient areas. And folks were super creative and really had fun with this. And we gave them an ice cream party after. Actually, we haven't yet. The winner has an ice cream party coming, and then COVID hit, and we have not yet done that. But that will be coming to the winning area at some point. And then we did a lot of internal communication. We have, the TVs, the display boards throughout our various campuses and outpatient clinic sites, where we really promoted the importance of colorectal cancer screening and awareness. And some other things that we did outside of our sites, outside of our physical locations, was really utilized our social media platforms. And so Twitter, Facebook, our internal Geisinger intranet to promote the importance of screening. We included, again, a lot of the same materials and information in our newsletters for both our health system as well as our health plan. And we did some education on the homepage of our patient portal. We partnered and communicated quite a bit with our local nursing schools, as well as we have a Geisinger School of Medicine that we did the same to really try to educate our future clinicians. And then we developed some internal educational videos that we shared within Geisinger. And I think, this year I would say was probably the most robust marketing campaign efforts that we've made that were successful, and I think we'll just continue to expand upon those in the coming years. They were really So this is pretty new and exciting, our mobile health service bus. So like probably all of you, COVID has really affected our patients in a number of what I would say negative ways. There was a point in time when we had canceled our non-urgent and emergent appointments. Patients are afraid to come out into the public, to come into a healthcare facility. Dealing with a lot of barriers and obstacles when it comes to COVID. So we really recognized and we've embraced the need to expand our telemedicine services, as well as offering a more, what I would say, proactive outreach to our patient population. So this summer, we started about 2 weeks ago. We're doing a couple road trips a week. We have a mobile health services bus that we are bringing to a number of our primary care sites. Our goal is to offer the preventative care screening, so colorectal cancer screening, breast cancer screening. If the patient is a diabetic, they can have their A1C drawn. We have a retinal camera that we have on the bus. We'll take a urine sample for nephropathy screening. So these are all things that we're trying, I wish we could drive this bus to patients' houses and do everything we need, but, we're parking this bus in our clinic site so patients don't have to actually go into the clinic, and it's not a staffing burden in the clinic sites. We are staffing this with our Care Gaps team, our quality team. A number of folks have joined in this effort. And it's really just to help get patients the care that they need. We're certainly adhering to social distancing guidelines and recommendations. We, unfortunately, due to the circumstances, we are limiting the number of people that are invited. It is by invite only. Someday, I hope to have this just be a free-for-all and open it up to the public. But certainly right now, we cannot do that. And you'll see, that's a picture of what our health services bus looks like. There's multiple triage areas. There is a full private exam room in the back of the bus. We have a lab draw station that our phlebotomist sits at to collect any labs that are overdue. A nurse's station, there is a bathroom, which is where we collect for the nephropathy screening. So that's really new. Like I said, we just started 2 weeks ago. I think today was our fourth trip, and patients love it. Our staff loves doing it because they find it so meaningful to be going out and helping people that may not have otherwise maybe gotten the care that they needed. Some of the other things that we're doing, we are doing a fit kit mailer to all of our GHP Medicare patients that are non-compliant for colorectal cancer screening. Our hope is to, do it this year, but again, given current circumstances, we weren't able to do that. But in 2021, we'd really like to expand this to all payers. And then in terms of, telemedicine, during, cancellation of our non-urgent emergent appointments, and, obviously screening colonoscopies were one of those things that were temporarily suspended. We did some telephonic outreach offering Cologuard to those who are clinically appropriate. And then when it comes to I think a lot of you guys out in primary, if you're involved in primary care, we've really seen a greater shift towards televideo or telemedicine visits. And so, coming up with workflows that were efficient for our providers and our nursing staff during those visits, and ensuring that we can continue to address open gaps in care during those visits. You really don't know, if what you're doing is working or not unless you measure it. So, when we first started our colorectal cancer screening initiatives, we needed, obviously, first to collect baseline data. And you need to compare that over time. Are you trending up and improving, or are you not? Areas of opportunity. But certainly if you are on the upswing and seeing improvement, you have to celebrate those wins. You have to. It really helps keep people engaged in the process and continuing to strive for even greater improvement. And then you need to continue to watch that over time, the trending of that over time, and make adjustments, kind of like the PDSA cycle, make adjustments as needed. Here's an example, and this is really where, excuse me, and this is what I would say is our source of truth for our primary care quality metrics, and where folks should have it saved in their favorites. But this is what we call our primary care quality and disease management dashboard. We have 6 system, you'll see more than 6, and I'll explain why in a minute, but we have 6 system-directed priority metrics that we focus on in community care or community medicine. So the first couple on here, there's 3 diabetic measures, which I've already alluded to. So A1C control, we want folks to be less than 9. This measure is actually inverse, so the lower the better with this measure. You want to see the least amount of people with an A1C greater than 9 as possible. Retinopathy screening and nephropathy screening for those patients that are diabetics. And then certainly blood pressure control, breast cancer screening, chlamydia cancer screening, and colorectal cancer screening. So chlamydia cancer screening was one that we had a number of years ago because it was an area that we had struggled with tremendously. We've made great strides in that, and we will be eventually replacing chlamydia screening with blood pressure control. But highlighted on this dashboard is our year-over-year colorectal cancer screening compliance rates. And so you'll see from June of 19 through June of 2020, we had a 3.3 improvement year-over-year. There were some points within calendar year 19. We were at the highest we've ever been, which was 71% in December. And then it's kind of a little, up and down, but sitting around 70. When I started working on colorectal cancer screening a number of years ago, we were about 63%. So, really in about 6 years, we've increased 6%. But again, our goal is 80, so we certainly have room to continue to improve. In this report, folks have the ability to drill down, obviously I'm showing you a system view right now, but folks have the ability to drill down to the provider level as well as the site level. And so this is fully transparent. Everybody has access to this and can see how every primary care physician is doing in the system as well as, site to site. So what was really big for us was transparency. And then on the right-hand side, you'll see our benchmarks. And for colorectal cancer screening, it's 80%. Our benchmarks for all of these measures actually were established utilizing the NCQA 75th percentile, and that was a system decision. The next slide is just, I love graphs. To me, graphs tell a story. It really shows the overall progress or not for each measure. So it's just a trending view for each of our priority metrics. Another report we have, and I mentioned this, I believe I mentioned this earlier, but it really comes down to accountability and folks owning this as their own for their patients at their sites. And so we have one report. It's called the Missed Opportunities Report. It looks at quality measures that were not addressed within that office visit. And then I have I would say the criteria or the couple items that satisfy that opportunity within the office visit. So if that gap itself is completed or closed within 10 days of the visit, an order is placed, the patient declines, and that's documented appropriately. We really want to understand, our hope, and I know it's not feasible all the time, but, our hope is for all gaps to be addressed at every visit. Again, I don't have delusions of grandeur. I know that's not always possible, but that would be ideal or pie in the sky state. You have the ability to drill this report down by site, by provider, by nurse, daily. You can look at the trending of the various missed opportunities by measure. You can look at it, percent missed opportunities. And what's nice about this too is you can drill down to the patient level. So, we may have a provider with a very high missed opportunities in colorectal cancer screening. I don't believe it helps to just say, oh, you're not addressing it. We need to show people, again, transparency of data. Who are the patients they didn't address it on? Here, the proof is in the pudding. Here it is. And to really help engage and hold folks accountable, because this is just so critical for the care of our population. The next report I have, we implemented this a couple years ago. They are called our provider scorecards. The concept was around the thought of a baseball card. So, on the back of a baseball card, it has all the stats for that baseball player. Well, this is kind of the same concept. We have providers, I shouldn't even call it provider scorecards anymore, because we have scorecards at the clinic level, at the provider level, and at the nursing level. And so this really just gives a snapshot of our metrics that are most important and part of Geisinger's pillars of care. And so there's a section for patient satisfaction, for access, ED and inpatient utilization, our mail order pharmacy utilization, our priority quality metrics, and then market, which market encompasses our missed opportunities and our HCC capture. And so, again, this is a snapshot in time. It says at the bottom when they're updated. Most, it's updated monthly. And so, again, we have the ability to drill down to the site level, to a provider level, and to a nursing level. And this is everybody's snapshot of how they're doing. And then certainly they get these on a monthly basis, and folks hope to see improvement month over month. So talked about it again, you know, I'll talk about it again, but this accountability is key. You know, leaders are, I love this quote, leaders are accountable for accountability. There is no I in team. Everybody on the team plays a part in this, on the care team plays a part in this. So from the care gap staff outreaching to patients coming in, and the nurse addressing the alert, and then the provider, you know, addressing it again if needed, to checkout, making sure that if something was scheduled, that it gets scheduled at checkout at point of care. This is a huge joint effort. There is not just one person that's responsible for colorectal cancer screening in our health system. Certainly, again, leadership support for the mission and the importance of colorectal cancer screening, being committed to achieving our goals. It starts at the executive level down to, you know, our primary care leadership, down to the site leadership, our quality department. So a number of people that are responsible and accountable for ensuring that we have improvement. And then one thing that we noted that was crucial to our improvement as well was having champions on the front line. So our ops managers at the sites promoting this, educating on this, continuing to share the importance of it, and sharing the stats for those sites and those providers. And then providers and nursing staff having a champion at each site, that this was really a passion for them, and that they can share that passion with other staff in the office. So I alluded to care teams a number of years ago. We really wanted to get away from, you know, just the provider model per se, and move to a care team model. So this goes from the lone doctor who has responsibility for all the patients to a very robust, multidisciplinary, high-functioning team. The transition from my patients to our patients. The transition from he or she to they. And when I say that, instead of focusing on individual patients per se, moving to a much more population health concept model. And so you'll see all of the care team members and groups of a patient's care team within Geisinger on this slide. So, you know, it really takes an army. So this, it hasn't been smooth. We haven't done this perfectly. We've learned a lot of lessons along the way, some of which are creating reliable and consistent workflows. Within the EHR, trying to have the least amount of clicks and being as efficient as possible for our providers, automating as much as we can. Communication. We have to continue to talk to our staff about the importance of it, the significance of it, transparency of data. Where are we now? Where do we want to go? How are we going to get there? Again, really piggybacks on the communication, but the continued education of providers and staff. Celebrating our success. So a couple years ago, with the development of the dashboard, we developed a community medicine quarterly quality award, and we have 2 awards for that. We have best in class, so those sites that have the highest scores in our various priority measures, as well as recognizing those sites that have the most improved quality scores for our quality metrics, and that has been really well received. Folks are super excited every quarter to know who won and who was most improved. And then I did already, allude to this already, but truly the transparency and sharing of the data. All of our data and reporting is available to everyone across the system. And again, continuing to regularly update folks on where we're at, where we want to go. so folks are aware of that. So thank you. I'd like to open it up to questions.
Thank you so much, Nicole, for that fantastic discussion. We unfortunately are almost out of time, so we will try to squeeze in 1 or 2 questions. Please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we'll try to get through a couple of them. If we don't get to your question, Nicole will follow up after the webinar. So one of our questions a member asked was, since Geisinger Health System offers choice in CRC screening options, how well do you believe your providers and staff are able to articulate and or differentiate the various options? What advice would you give to systems that are starting the process of aligning their providers around CRC recommendations and SDM?
So certainly, I think we always have room for improvement around this. I think our providers and our staff are much more comfortable talking about and discussing the various CRC options with our patients than they ever have before. But not, but it doesn't stop there, right? That continued education needs to continue. And it certainly didn't happen overnight. This has been years in the making. So like I said, over the last couple of years, we've really put a tremendous focus on colorectal cancer screening in primary care, including, the education for our providers and nursing staff, the motivational interviewing. We needed to do this in order to see improvement, and we recognize that. My advice would be education, education, education. You truly can never get enough of it. I think the more folks understand the importance and the significance of screening, the more they'll do it. You got to be patient. Again, this doesn't happen overnight. It takes months to years to truly see a significant impact. And I think folks have to celebrate the small wins as you can.
I completely agree. We'll have time for one more question, and this one is, what types of success have you had in reaching your population that is unscreened?
So a few slides ago, I did show, we've seen a 3.3 improvement in our screening rates year over year. We continue to strive to reach 80% compliance. I think, again, the provider and staff education around the various screening options, as well as the implementation of our shared decision-making tool that I shared earlier, hopefully is greatly being utilized at point of care, has been super beneficial for patient engagement and compliance. Again, we've partnered with our Exact Science reps. We've worked diligently to recruit in GI to have better access. And then we just continue to do some of the various proactive outreach strategies that we're doing now that I alluded to. So to get to those that are still remain unscreened. So the mobile health bus, the care gaps outreach, the happy birthday letters, the chronic disease letters. We try to reach patients in a number of ways to get their attention and to get them engaged.
Well, thank you so much, Nicole. That's all we have time for today, but I just want to, again, thank you for your excellent presentation and also thank Exact Sciences for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.